Welcome back. This is our mental and behavioral health panel. We last year had some feedback that, these are great events, and then we don't see a lot of you for another year, and it would be nice to do some things continuously throughout the year. And so we did a little webcast in Atlanta. We got snowed out the first day and had to reschedule, and it turned out really great. And one of the topics on that webcast was rural mental and behavioral health. And that's available online. If you're interested in this discussion, we'll try not to duplicate it. We'll try to touch on some different areas, and you can go find that on our website. So we're going to continue that discussion today. Some of the panelists that were on that are graciously back to discuss more, and we have some new panelists. So excited to introduce everybody and talk about this subject where there is some real severe shortage and a very important issue. I'm going to let everyone do sort of self-introductions, but generally I can help introduce the panel. On our left, we have Dr. Kailyn Lane, who's a triple board-certified child and adolescent psychiatrist who's based in Southwest Georgia, but as we'll talk about a little bit later, is part of a program that seeks to treat patients in Southeast Georgia and hopefully elsewhere, and that's part of the future of psychiatry, I believe. To her left is Dr. Ron Manderscheid, who is with the National Association of Rural Mental Health. He's the executive director, in fact, and he's visiting us from DC, and we're very grateful to have him here. We have Jennifer Dunn. She'll take it. I mean, we want to call her a doctor. She's not going to. Jennifer Dunn is with the Georgia Department of Behavioral Health and Developmental Disabilities. DBHDD is the very catchy acronym they have for that one. She does the regional administration for Region 4. So she's here and plays a very important role in this administration of mental health services on behalf of the state. And then we have Dr. Sarah Vinson. Again, this is a pretty impressive group here. We've got another triple board certified child and adolescent psychiatrist. Sarah is here from Morehouse School of Medicine, and she was also on the webcast. So we'll start with Dr. Lane, and if you want to give a little bit more of a full-fledged introduction to what you do and what brings you here.
Sure. Well, I'm a graduate of UGA and MCG, and I currently work as a medical director for Unison Behavioral Health. In Georgia, we have a series of CSBs, or community service boards. Unison is one of those. Unison is based out of Waycross, Georgia, which is in southeast Georgia. I've been the medical director for almost 2.5 years now, and also treat patients there as a child and adolescent psychiatrist primarily, although I do occasionally see adult patients as well. I do all of that remotely from my home, which is 3 hours away in a small rural town in southwest Georgia. And so telemedicine is very important to our agency. It's important, I think, to our country, and it's become a passion of mine that I didn't exactly foresee when I started doing it. And so we are attempting to provide mental health services for the mentally ill, services for people who have substance use disorders, as well as developmental disabilities. In an 8-county region in southeast Georgia, a very rural area. We serve 8 counties. We have 6 clinics, so we have 1 clinic in 6 of the 8 counties. And we also run a crisis stabilization unit and a residential substance use treatment facility. And so that's just a little overview of what I do.
Dr. Manderscheid.
Yeah. I'm Ron Manderscheid. I represent the National Association for Rural Mental Health in DC. I also represent the National Association of County Behavioral Health and Developmental Disability Directors. So we have about 2,000 members. Most counties that have behavioral health services are part of our organization. And there's an overlap between these two groups. Obviously, the National Association of Rural Mental Health is partly composed of county behavioral health directors in rural counties. It's also composed of providers in rural counties, and it's composed of researchers. It's kind of a unique group. It's a little group. They're having their summer meeting in New Orleans from the 26th to the 29th of August. If you're interested, you're very welcome to come and join us for that meeting. I also teach for the Johns Hopkins University in the School of Public Health, and I teach for the University of Southern California. By background, I was, in my career, spent many, many years at the National Institute of Mental Health and also at the Substance Abuse and Mental Health Services Administration. I worked on Clinton healthcare reform, and I worked on Obamacare.
Wow, that's hard to follow.
So you're inviting us all to New Orleans, is what you're saying?
You're all coming to New
Okay.
Orleans.
You might find some
Bourbon
takers.
and Canal Street.
Good afternoon, I'm Jennifer Dunn. As Mason mentioned, I work for the Department of Behavioral Health and Developmental Disabilities. I'm the Regional Services Administrator for the 24-county area in Southwest Georgia. So that would be the area that encompasses Valdosta, Thomasville, Albany, Bainbridge, those counties over there. I work with 3 community service boards in my neck of the woods, similar to what she mentioned earlier with Unison. And I'll just say that I spend a lot of my time on the phone with ERs, with sheriffs, with providers, and I'm hoping that some of the conversation today can stimulate the ability for us to connect. You know, we talked earlier today about it being a small world. I just met somebody in front of me a while ago, and she went, she was a nurse with my mom. We're from the same area. I do think that is one of the advantages we have, and that's one of the ways we can succeed is just by talking to each other. So I appreciate the opportunity.
And Dr. Vinson has you'll introduce yourself, but you also have a little presentation to kick things off, which would be great.
Good afternoon. My name is Sarah Vinson, and I'm a child and adolescent psychiatrist based in Atlanta, Georgia. I'm an assistant professor of clinical psychiatry and pediatrics at Morehouse and adjunct faculty at Emory. And I'm currently the president of the Georgia Council on Child and Adolescent Psychiatry, which is the state child psychiatry group. And I have worked in public sector children's health since I moved to Georgia 8 years ago, and currently am a provider at Metro RYDC, which is one of the essentially kid jails in the Atlanta area. But we do pull kids from all over the state, and I've also worked at Viewpoint, which is a regional center that pulls kids from all over the state. So even though I'm based in Atlanta, these issues definitely affect patients that I see. And I'm originally from Northwest Florida, which has more in common with South Georgia than Atlanta does in a lot of ways. So I just wanted to talk about juvenile justice and youth, and I'm actually the daughter of a probation officer, so juvenile justice and some of those disparities and how unmet mental health needs kind of filter into the criminal justice system is something I've kind of grown up with. And we'll talk really briefly about some of these things. And I think one of the big things to point out, and with this crowd, you're probably aware of this, but there's this idea that the kids who end up incarcerated are bad kids or that they're the delinquent kids. And that doesn't always track the way that people may think it would. And so detained youth really aren't representative of all of the kids who do things that could potentially get them into trouble. And there are things that are criminalized now that may not have been criminalized 20, 30 years ago. And to the extent that we follow the statistics, and we do this on state and national levels, we always see that there's this disproportionate minority contact at every stage of the criminal justice system. And when I was able to find statistics specific to rural areas, we definitely see that there as well. And it may even be more pronounced in terms of the overrepresentation of Black and Latino youth who face harsher penalties. And what I also see, both as someone who works within this system and who has a private practice where I do forensic psychiatric consultations, is that who gets locked up or who gets involved with DJJ has less to do with what they did, with the resources that their parents have and where they are. And so there you have the affluenza teen who recently got out on house arrest, right? So the kids who tend to get locked up are the opposite of him in a lot of ways. So these are the kids who are reliant on overburdened public systems to help them, who are often children of color, often children who don't have means. But we also see a high overlap of children who are on the wrong side of social determinants of mental health and who have a high trauma load as well. I think it is worth noting, though, that while they are in the DJJ facilities, they're not just being warehoused. And unfortunately, often they have better access to mental health care services, particularly specialized mental health care providers, once they're locked up, and they do in the community sometimes. And they are on facility-wide reward systems receive things like yoga therapy, even sometimes, which would be very hard for them to access in the community. And they do have access to board-certified child psychiatrists, which can be very hard for them to get in the communities. But of course, it's not somewhere that you want children to be, and they definitely do end up there longer than you would like, and there's a lot of turnover within the system. And particularly for our rural kids, especially when they end up in facilities like mine, a lot of the kids who are there kind of know each other and they run the streets together, and so if you're a kid from the outside, it can be a harder place for you to be because you're not connected to folks the way that the other kids are. And just in general, and this probably isn't surprising to people, but when you look at the rates of mental illness in kids who end up incarcerated, of course they're much higher than kids in the general population, both in terms of just having a mental disorder of any kind, but also when it comes to having severe mental health disorders. And then we see a lot of trauma. And the reason I have that multi-headed monster is because trauma can manifest in so many different ways. And a lot of those ways that it manifests put kids at higher risk for contact with criminal justice or juvenile justice because it's hard for them to conform their behaviors. They get kicked out of school, they're on the streets, there's lots of opportunities for mischief. And so trauma is a huge player in the kids who are in the juvenile justice system. And when you look at girls, when you look at boys, the numbers that report abuse are really incredibly high, and we know that these are probably underestimates in a lot of ways, but it's the rule rather than the exception, and a lot of times it just may take more time for those traumas to come out. There's a lot of emphasis on what's happening in the inner cities and the violence there, but the reality is it's not easy in rural America either, especially with some of the things that communities are up against economically. We know that when parents struggle, kids struggle, and things like neglect that may not get as many headlines definitely have negative outcomes on children's mental health. And so, you know, in rural communities, you kind of have this two sides of the same coin where you have small communities where you may have closer networks, but it's also easier for a kid to become that kid or the bad kid in those smaller communities as well. And what I find is that a lot of the kids who are there, it's because of a multi-system failure. So if their reading disorder had been caught earlier and they could stay engaged in school, they may not have ended up in DJJ. If the DFACS process had gone more smoothly for them, they maybe wouldn't have ended up there. And then of course, our mental health care system is really underfunded and decentralized, which makes it hard to give children the care that we would like for them to. It's hard when the parents don't have access to mental health resources. It's a lot of work to raise a child, even if you have a typical kid, so you throw in a mental illness and you throw in a parent who may have an unmet mental health need, and it's a really high ask of them. And then of course, when you're thinking about disposition planning or alternative plans, it's harder in communities that don't have the professionals or the systems to provide the care in the same way. And of course, a lot of the things you've heard this morning are about how rural America is struggling, and so those social determinants of health have downstream effects on children's mental well-being. And that's it.
Well, great, thank you. Then that's a really great segue into what we're going to have as our first topic, which, you know, the state of Georgia has been subject, continues to be subject to a settlement agreement with the U.S. Department of Justice because we weren't doing a great job of caring for the mentally ill population in the right setting. And so as part of that settlement agreement, I know we've made, you know, collective efforts to try to move patients out of the institutional setting and into a more community setting. Jennifer, I'll let you speak to all the great things DBHDD is surely doing as part of that settlement agreement. And I think you'd be the most expert here to speak to that, and then we can talk more broadly about some trends nationally.
The settlement agreement started in 2010, and there's been so much that's been done, it's really hard to keep up with it all. Most of it has to do with getting people access to care closer to home and getting the right level of care that they need. We have put, I can't even remember, I can tell you in the 24 county area that I represent, over 850 people in housing, which means we're paying for them to have a place to live and in some cases their utilities if they don't have access to benefits. The population that are going into these homes, into these apartments, are the severely and persistently mentally ill, those who have a severe and persistent mental illness with diagnoses like schizophrenia, bipolar, schizoaffective, and things of that nature. We have a number of assertive community treatment teams, which are commonly known as ACT teams, and those are teams of individuals, professionals with doctors, nurses, psychosocial rehab folks, who go out into the community and meet the person where they are. So instead of having the person come to a clinic traditionally to get their services, some people, walk into a doctor's office, and if they're, having some paranoid delusions, it might make them even more concerned. And so having basically the clinic go to them. And so this team of 10, which also has a peer specialist on it, so somebody that's been there and done that, a voc rehab specialist, somebody that can help them get a job if they wanted to. So those are the kinds of services that have been real instrumental in getting people services that they didn't have, more than 8 years ago. We're still in the settlement agreement. I know if you want to read up about it, because we get these nice reports, they're on our website. I think the most recent one is on the website, and it just was published this past week. So does that help answer the question?
Absolutely. And Dr. Manderscheid, speak to some of what you're seeing nationally. And we spoke yesterday. Dr. Manderscheid was speaking with a hospital CEO here in Georgia about a program out in Washington County, Oregon, I believe, and some trends in that area you're seeing nationally.
First, a little bit of follow-on to what was just said. So nationally, there's still a lot of effort to implement the Olmstead Supreme Court decision. And what was just being talked about is the application of that Supreme Court decision to basically adults with serious mental illness. Well, that applies also more broadly to other populations. It applies to people with intellectual and developmental disabilities. It also applies to people in jails who have these conditions. So you're going to see more and more of this play out as the Bazelon Center in DC brings lawsuits in favor of clients in these settings whose rights are being violated. So look for more of these actions through the Justice Department and as a result of the Bazelon Center activities. So to put in a little bit of context on mental illness, so if you look nationally at the issues of mental illness and substance use, you're talking about 80 million people in the US population per year. It's a very, very large number of people. And that is about 32% of the population. If you look at people who have serious mental illness, it's about 5% of the population. So you're dealing with a very pervasive problem, and it exists in every facet of the population. Doesn't make any difference whether you're in the lowest social class or the highest social class, or whether you're a minority or not. It affects everybody. So what we're trying to do is make the treatment programs more relevant to specific groups. And I want to bring out a couple of features here that will be useful to the hospital directors here. So one of the issues in this population, adults with serious mental illness, is the fact that we are now seeing a huge number of adults with serious mental illness who also have opioid problems. Well, that's something fairly new, and I would say today, anecdotal data, there's no federal data, anecdotal data would say at least 50% of the people who are adults with serious mental illness also have opioid problems. So if you look into that a little bit, you'll see that of the 150 million prescriptions written a year for opioids, 51% are written for people with mental illness. 51%, just imagine that. And imagine then the complexity that that brings to the care of a person who is an adult with serious mental illness. Now, that's one side of the issue. The other side of the issue for the hospital directors would be there's a lot of new money being put on the problem of opioids. Maggie told you that. There's $6 billion of brand new money that was not targeted money, $3 billion in 2018, another $3 billion in 2019. So the question to the hospital directors would be, how can you plug into some of that money to begin working with this complex population, people who are adults with serious mental illness and who also have opioid problems? So another example of this would be, bring it into the jails a little bit. So if we look at the jail, and you raised the issue of jails here, so in the county jails today, probably in every county jail in the United States, and there are 3,069 county jails in the United States, tonight they will house 750,000 people. And of those 750,000 people, 75% at least, in many places as high as 90, are people who have a behavioral health condition. Most of those people should never ever be in jail in the first place. They should have been diverted through the county behavioral health program, and for whatever reason that didn't happen. The epidemiology would say if you become mentally ill, you're at very high risk of becoming homeless. If you become homeless, you're at very high risk of going to jail. So we haven't broken that chain here. So once these people go to jail, Medicaid can no longer be used for their care in a way that it can be used when they're out in the community. And because of that, the counties are at total risk for the financial cost of the health care of people who are in the county jails tonight. So if I were in the county jail tonight and I needed a heart transplant, legally the county would have to provide me with a heart transplant irrespective of the cost of that transplant. So the counties are looking for solutions to that problem. So you, the hospital directors, can you bring them a solution to that problem that would reduce the prevalence of these disorders in the county jail, because we know it costs a lot to house them there, we know it costs a lot to provide care for them there, and Medicaid can't be used. As soon as they're outside of the jail, Medicaid can be used. So there's another kind of solution here that would work for a county hospital. Kind of a third dimension of this would be what Mason was getting into. We are developing in counties now the concept of a county urgy behavioral health center. A county urgy behavioral health center is a facility in the county that's totally open. So anybody can come there. You don't have to have an appointment. You can come yourself. A family member can bring you. A peer can bring you. The police can bring you there. It's a 23-hour and 59-minute facility, and it will do whatever is needed for that person. So very many people are brought to these facilities because they are beginning to decompensate in various ways. They're decompensating with mental illness, or they're decompensating on drugs. That facility existing in the community is totally eligible for Medicaid payments, the one that Mason was talking about, Washington County in Oregon. I have a webinar on that program. Be very happy to share that webinar with all of you. Is now beginning to pick up their Medicaid payments, so they've gone from 0 Medicaid payments 15 months ago when they started to now about 65 to 70% of their revenue is for Medicaid payments for that population. One other idea that relates to this, they were given the building that is their county urgy center by Google, because Google was moving on to a better building. They said, we have to get rid of this, we'll give it to the county and take a tax deduction on it. You can get grants from the U.S. Department of Grants, wrong word. You can get a loan. Grants you don't pay back, loans you pay back. You can get a loan from the U.S. Department of Agriculture to build a building with a 99-year length of time on the loan. And actually, since we talked about that last night, I now know from talking to someone else that at least one county in Georgia actually has one of those loans. I believe Morgan County has one of those loans from USDA to do that.
There's
so
others.
That's yours? Okay.
No, there's others.
There's others, there's
Yeah,
others.
yeah.
So, okay, so that is another mechanism that a rural county can use to do some of the things, to put some capital into a system that wouldn't be there otherwise. One final idea, and then I'll stop here. One final idea, we talked also yesterday about federally qualified health centers, and it's probably true that a hospital cannot manage a federally qualified health center, but there's some other relationships. A hospital could become what's called an FQHC lookalike. If you become an FQHC lookalike, then you start becoming eligible for higher Medicaid reimbursement and so on. Those relationships are worthwhile looking into. Let me stop.
We have Reggie Taylor here now from the USDA, and I think they're all going to hold you to this, Reggie. They just heard about these loans. All right. I was going to say, Reggie's passing these out after the symposium.
Can I add one thing?
something to what he just
Yes,
said?
of course.
You know, we've just funded through our department what we're calling housing outreach coordinators. They're in the jails, and they are through our community service boards, and they're going into the jails to do assessments and housing needs assessment forms to figure out who in the jail does have a mental illness, who qualifies for this. So that is something that we started back in January. It's a fairly new program. I've been taking around some local HOCs, as we call them, and introducing them to sheriffs, jail administrators, and the like. The other thing you just mentioned in Washington, is it Washington County?
Washington County, Oregon. Yeah.
In our state, we have what's called a Behavioral Health Crisis Center, BHCC for short, and it is exactly,
the same thing.
yeah, they're exactly the same thing. Anybody can come in 24/7, 365, and in rural Georgia, where I'm at, in Southwest Georgia, we have 3. We have one in Valdosta, one in Albany, and one in Thomasville, and it does have the temporary observation, and it could be somebody that just missed their appointment and isn't feeling great, and they don't need an inpatient stay, but they need to talk to somebody. And so I kind of look at that as a navigation unit where they're navigating them to the right level of care. Maybe it is that 2359, maybe it is more inpatient. And so those have been very successful, and we have a few more around the state if anybody wants to know where they're located.
And the community service boards are the ones
That's who
administering
operates
those,
those,
right?
correct.
That's Dr. Lane works for community service board, and I want to get to, speaking of alternative settings for treatment, the work you've been doing to implement a school-based program, and school-based mental health has been a hot topic in Georgia lately. It's $20 million, I believe, in the governor's new budget for it, and Dr. Lane has been out there plowing the fields with this. So if you want to talk about that program and sort of what it means to the communities and some of we'll get into the stumbling blocks in a little bit.
Okay. So I work for Unison Behavioral Health, which is the CSB based in Waycross, and we cover 8 counties. We have the good fortune of having good relationships with the schools in all 8 counties, and we have agreements and arrangements such that our therapists, our counselors, can actually go into the schools and have appointments with kids, with students there. That has been wonderful for many reasons. It increases access to care, clearly. It also allows for better interaction between the mental health professional and other people that are important in the student's life, teachers, principals, guidance counselors, and not just parents. We also have wanted to expand mental health services to include psychiatric services in the schools. And of our 8 counties, 3 of the counties actually are equipped and set up for telepsychiatry services. So they have, all the necessary technological equipment to be able to have those appointments. And that is something that I've been doing as a child and adolescent psychiatrist, that I've been doing evaluations and medication management follow-up appointments in the schools. And it's an excellent service for many reasons, and I could spend the rest of the day talking about those, and I won't. But there are definitely some barriers to it, both at a state and a federal level, that I'm hoping will start to disappear. And in order for not just us as an agency, although that's my selfish concern, is I want us to do what's right, but at a broader level for us as a state and as a nation, to be able to expand and improve access to services for students in the country. I mean, unfortunately, with recent events, I think everyone recognizes the need for mental health care in general, but certainly in schools. And improving access for the students, I think, is very, very important, and it's tops on my list of priorities.
So the Congress just passed what's called the Stopping School Violence Act. And that will put $500 million out there to increase mental health care in the school system, which is another national trend. Many community service boards nationally are expanding their programs from their own facility directly into the school, basically. And the Stopping School Violence Act will put additional money into that activity. It's not for metal detectors, it's really for improving behavioral health care in the school, some training for teachers, adding some school psychologists, these types of things. So children with problems are detected earlier before they go critical.
Yeah, and you know, we're at the law school, so we will talk a little bit of law here, because I think it applies to telemedicine or telepsychiatry writ large, not just this particular program, but you know, there aren't going to be psychiatrist trees growing out of the ground anytime soon, so we're going to need telepsychiatry as part of the plan for mental health in the future. There is a state rule in Georgia, but there's also a federal law that says if you are going to prescribe a controlled substance, that you need to first have had an in-person encounter with the patient. And that's sort of made some waves lately, because in the opioid space, people are wanting to be able to prescribe Suboxone, but without having to have an in-person encounter first. But it's been playing out in this mental health space for a while with ADHD medications like Dr. Lane is wanting to prescribe and that are much needed. I think 122 out of Georgia's 159 counties don't have a child and adolescent psychiatrist, and I talked to Dr. Vincent about that. She said, I'm surprised it's that many, you know?
Yeah.
So what do we all think about this? We know that it's a needed service. We know that we'll probably get there eventually. There are some camps on the other side. You can speak to these particular laws, but you could also speak to the relaxing of laws to permit telepsychiatry generally. Whoever wants to take it.
Well, let me start with the opioid issue a little bit more generally. So if you look up at the highest level here, you're talking about 8 million people in the United States do drugs of some level, about 2.5 million do opioids, and we're losing about 65,000 people a year to death because of opioids, and that's a 2016 number. We expect the number in 2017 to go up a little more. So the issue becomes, how do we respond to that growing problem? And Maggie said the problem is worse in rural areas than it is in urban areas. And for you, what role can community hospitals play in the care of people who have these opioid problems? And for prescription of certain of these medications, buprenorphine, for example, requires that a physician have some training before the physician can prescribe the medication, and then the physician is also limited in the number of people they can treat with buprenorphine at the same time. That number's been shifting, so it originally was something like 75, then it was 200, now I think it's 400 people. So there, again, in this, there's a role for community hospitals of being engaged in this treatment, and if done in the right way, I think you could combine direct treatment with telemedicine interventions in a way that would work, where maybe the community hospitals in the state could share resources to do some of these things. So I think there are huge opportunities there right now in fiscal year 18 and fiscal year 19 that probably won't be there after this period. So if you're going to do something in this area, you probably want to get into that very quickly here.
Jennifer, is telepsychiatry on the radar of DBHDD?
Oh, yeah.
Or are you doing some things with?
Absolutely, and you know, as he was talking, I was just thinking about we've had some local communities that have gotten together and formed what they call recovery-oriented communities of care, where we're having local conversations with. We recently did one in Tifton at Tift Regional, where we had the behavioral health providers, we had addictive disease providers, we had methadone treatment providers that are not typical in our service area, but we do have some. And we all got together with families and individuals who are in recovery to talk about what do they think the needs are, and just having conversations very similar to what he just described, and what is it that we can do locally, because the problems we may have in Tifton might be slightly different than what we have in Albany, which might be slightly different than what we have in Jefferson County or some other rural areas around the state, or up in the northwest part of the state. But I think just having those conversations and talking about it and connecting with folks like we're doing here today is how we're going to be able to solve some of it. I think somebody mentioned this morning, you got to eat the elephant one bite at a time. It's a big elephant, and so just at least acknowledging it as an issue and discussing it. I personally have had relatives or a relative who has passed from an opioid overdose, and it does not matter. It doesn't matter who they are. And this wasn't somebody that was a typical drug user either. And they had some shoulder surgery. One thing led to another. Anyway, you can see how easy it is for these folks that need these services so desperately to identify. And back to what Dr. Lane said, being able to connect with them, even in the school systems, partnering with those communities, whether it's schools, churches, jails, whomever. That's where we're going to reach some people, because we can get to maybe their broader system of care.
Well, the other thing to think about that I think is often easy to overlook in terms of the opiate epidemic, or really just any issues related to substance use disorders, are that they don't just affect the user and the adult family members. You know, it affects the kids, and that in some ways, I feel like in child and adolescent psychiatry that trying to provide services for kids and trying to help kids through trauma, neglect, abuse that many times resulted from substance use, hopefully we will steer some of them away from following that same path, because certainly genetically they're at risk. If their parents have substance use disorders, the children are at risk genetically for developing those as well. And then you add on the layers of trauma, and it really increases the risk of furthering mental health problems throughout their life. So in my mind, in some ways, providing mental health services for kids, and I think partnering with schools is one of, if not the best ways of doing that, will hopefully ultimately break that cycle.
And one other aspect of telemedicine is that integrated care piece, so working with pediatricians, family medicine doctors, and essentially providing phone backup for them as they do assessments or do limited interventions. And we do have CPT codes for that now in a way that we didn't before, and it's just going to be a matter of getting those funded and getting those supported. But there are programs in southern states that are doing this, and I don't see why there's a reason we couldn't do that in Georgia, and there's definitely a lot of interest in the pediatric and the child psychiatry community about being able to work together on a more sustained basis, because right now we are doing those things and we are providing trainings for general pediatricians, but it's all grant funded and kind of coming through us. It would be great if we had something that was sustainable.
So a couple of resources here that relate to this. So one, there's actually in Medicaid, you can do an 1115 waiver to create county systems of care for substance abuse. And if you do that 1115 waiver, you can be waivered from the IMD exclusion. The IMD exclusion, the Institution for Mental Disease exclusion, means that you cannot spend federal Medicaid funds on care of a person who is in a facility that's of size 17 or greater if that person is between the ages of 22 and 64. And that can be wavered off if you create a county system of care, meaning you can then use some of the money for community residential care of people under that waiver that you could not do if you did not have the waiver. So one tool to bring, in effect, more money into care of this problem around opioids. Another variant here that's worth mentioning, because you've talked about Medicaid expansion so many times in here today. So yes, there is Medicaid expansion. No, Georgia has not done it. There's what's called Medicaid Light. Medicaid Light, in effect, is taking a particular subpopulation. So you could take the subpopulation of adults with serious mental illness and say, you know, we have, however many, 20,000 or we have 50,000 of these people who are very complex cases who need special attention. We are going to come to CMS and we are going to get a special waiver to work with that particular population, which then makes some additional Medicaid resources available to work with that particular set of people in a broader way than you could under the traditional state Medicaid program. Several of the states that did not do the Medicaid expansion have done Medicaid Light. Virginia is an example of this, and Utah is another example of this, and that program is working very well in both of those places. So if your politicians continue to resist doing, you know, the full Medicaid expansion, you may want to do Medicaid expansion Light. And finally, there's also another program under the Affordable Care Act called the Health Home Program. It's Section 2703 of the Affordable Care Act that permits a state Medicaid program to make a request to build health homes. And the health homes, put into the context of a community hospital, would be a hospital and an outpatient program, in effect going together to do integrated care the way you were describing it. And what the money from CMS allows you to do, you get 2 years of infrastructure money to put together the infrastructure to do this, and you also get an accelerated Medicaid rate, I think it's 106%, to pay for persons who receive care in that program for the first 8 quarters that the program operates. You can get 2 years of money to actually do this while you're also getting the infrastructure money to do your IT and so on. So that would be another program you could look into to do some of these things you can't do because you're not doing the Medicaid expansion.
It's an important time for a reminder that we have this all recorded, and if any of these ideas, if any of these ideas are intriguing to you but you didn't jot them down, have no fear. Well, so a sort of related topic, and it's a pretty loaded topic, but it's in the headlines. Unfortunately, is this topic of school violence and gun violence, and often the headlines will be we need mental health reform. So I'm very curious. You're all welcome to pass if you want to pass.
No.
But I'm very curious to hear from experts' perspective. What do you think when you see headlines like that? And even if you may disagree that that's the primary culprit for things like gun violence, are there some things that the system can be doing better? And it's tough. It's not going to be easy, but are there some things that we can be doing to help try to avoid these tragedies?
So let me start. I won't be fearful of speaking to this. So, setting aside the issue of should you own guns or not guns and what kinds of guns you should own and so on, which, I have a particular opinion that I'll only talk to the other side. So I think a huge part of the problem of people in schools who do these shootings is the fact that people have gone critical and no one, including the people who knew them, the providers who knew them, the teachers who knew them, all of whom knew things were going off the rails for that person, did nothing to change the situation. That was true at Sandy Hook, that was true in Aurora, that was true most recently in Florida. And after the fact, you always hear the fuller story of all these people who knew about it and did absolutely nothing. So we have to change several things. We have to absolutely change the willingness of people to speak up. When you see something, you have to say something, you have to do something. And in the Aurora case, it even involved a psychiatrist at the University of Colorado who was treating that person who did nothing, basically. So we need to change the culture around that. Part of the problem, the culture around that, is because there's so much stigma involved in mental illness, people run the other way. People kind of have the feeling that you can catch mental illness if you're around people who have mental illness, so you run the other way, you don't want to talk about it. It's kind of like cancer was 50 years ago. 50, 60 years ago, when someone had cancer in a family, nobody said a word about it. Even the person themselves never talked about. Well, that's all changed. We have to change that regarding mental health and mental illness as well. And part of that's breaking down the role of stigma here. And as we talked before, it's very important to get care into these settings earlier so that the teacher is trained to recognize when a person is starting to get depression or they're starting to get more anxiety, et cetera, that these things are recognized earlier and they're intervened earlier, so you have fewer people going critical and decompensating and then taking one of these extreme actions which happen here. So I think there's a lot that can be done. We need to take the bull by the horns and actually do that as a society.
And just as a practicing psychiatrist and a forensic psychiatrist, I will say that even when we know there is a risk, we are limited in terms of what we can do until something has actually happened. When kids go in to be evaluated for inpatient admission or residential admission, if they don't clear that bar of the insurance company for inpatient admission, they let them right back out. And even when they let them in, they may be only in for 3 or 4 days, then they're right back in the community where they may not have the resources that they need. And so sometimes even when we see an issue, our hands are tied in a lot of ways until something bad happens. I will say too, and I understand not wanting to touch guns too much, but in Florida, he couldn't buy beer, but he could buy a gun that could kill a lot of people. I mean, just common sense, what we know about brain development, that the brain is still developing through the age of the mid-20s. I think there is room to be more practical in terms of what we allow people who we know are still in the developmental process to have access to. And then the last thing I'll say is a lot of times this conversation comes up around mental health provision after something bad happens. But the reality is, in most of these cases, not all, but most, a lot of bad things has happened to these children over many, many years. And it is a result of multi-system failure, not just the mental health system. And we talk about problems once they're manifested as mental health issues, but there are a lot of upstream effects, like single mothers not being properly supported, insufficient childcare, housing issues, food insecurity, not having enough behavioral health interventions or special education interventions in the school that all lead to this problem. And so if we really want to have a serious conversation, we can't start at the mental health system. We have to start at all of these other social networks and supports that are supposed to be in place for kids and that fail them consistently.
Well, there's this is a very wide-ranging topic. There's a lot we could cover. I wanted to get to veterans, for instance, PTSD. We live in a state with higher than average percentage of veterans that live in rural America, and certainly welcome that. But we have 10 minutes left, and I do want to take questions. So I think I'm going to open it up for questions now. Robin?
Okay, I'm going to make an editorial comment, more than a question. So one of the things that we recognized years ago when we struggled with the frequency of patients using our emergency room, the rising bad debt, which is this is a healthcare symposium here, and as we struggled with the patients who were chronically using our emergency room inappropriately, one of the first things that when you do a deeper dive and you look at why is somebody coming into the emergency room chronically for a backache or a toothache or got an earache or I just have a headache. When you look at them deeper, that in an emergency room setting, physicians, providers are trained to look at just the acute event. What's going on right this minute, right now. When you look at it in the trending nature, though, what we realized is that more than 40% of the patients that were overutilizing or utilizing our emergency room in an inappropriate fashion were people with behavioral health issues.
Yeah.
And so one of the things that we did early on was to engage and realize that behavioral health and developmental disabilities had to become part of our primary care environment. And so, so we partnered with our community service board. What I don't know, I can be, if I try to do things that I don't know an awful lot about, I can become very dangerous real fast. So we partnered with Kay Brooks in our Albany area community service board. And they right now, when you talk about keys to success, and I say this all the time, it's not one thing. I almost slapped somebody silly today about thinking Miller County was successful over one program that we had, but it's a string of events looking at your population and what are the issues that are driving those bad outcomes. And behavioral health is something that I just don't think hospitals historically have really addressed. Right. But we partnered with our community service board. They now have 2 sites on our campus. forensic as well as some other little program that
CST.
people could really
Yeah.
talk about?
Yeah.
That's
Okay,
it.
well, and then, you know, another byproduct of that ended up being the reopening of another closed hospital
Right.
that became a long-term model for people who came out of crisis.
Yeah, their Touchstone program took over the hospital that closed in Arlington, Georgia. And Touchstone is a program that the Community Service Board serves long-term for those people who want to be in long-term recovery for an addictive disease issue and may also have a co-occurring mental health disorder. And you know, one of the things is it's voluntary, so people can leave. And so that becomes difficult sometimes when, as a family member or as a practitioner, you want to help someone and you see the resource there, and they may stick it out for a little bit, but they may leave. But the thing is you don't give up and you keep trying because you never know. You know, it could be the 78th time that you try with somebody that it finally sticks. But back to what Robin was saying, one of the things that we've been real successful doing is having local community collaborative meetings where we meet on hospital campuses with the Community Service Board for Behavioral Health and Intellectual Developmental Disabilities. We have law enforcement there, we have the school system there, we have the coroner's office who has a suicide grant come, we have basically any private practitioner come, and in the 24 counties I'm in, we have I think 6 of those, and we again hold them at those local hospitals because of the people showing up with the headaches in the ER that really aren't needing that level of care. And we certainly don't want the ERs clogged. We'd rather them be treating the heart attacks and the things that they're funded to treat. And so if we can assist in those ways, that's one of the things we're doing. Those are happening all over the state. It's not just local to the area that I serve. So if anybody wants a schedule of when those meetings are, if you would like to come, we again meet quarterly all over.
So,
And the issue was it was never the headache.
Right,
Yeah.
it never was.
right.
It was never that.
So,
So connecting.
to your point here, so if you look nationally at the numbers, so for anybody who got any behavioral health care in a year, we're spending about $100 billion a year for that behavioral health care. For that same set of people, we are also spending $450 billion in health care, partly because we haven't completely addressed the behavioral health issue and people are coming back to the emergency room, et cetera, et cetera. So if we could do a better behavioral health job, we would be able to change that $450 billion a year. Then a kind of a local dimension to this, an important feature of trying to address that is also engaging peers in that process. In behavioral health, we use peers. Peers are people who themselves have had a behavioral health condition who work with us in all settings. They work in emergency rooms, they work at the front door of the jails, they work in the community mental health centers, etc. They can make a huge difference in what happens in those settings and who comes back. If you have a peer mentor for someone, they have someone to talk to. They don't need to come into the emergency room to have someone to talk to. So there are other strategies that can be invoked here where there's a lot of good national support, a lot of good evidence-based practice that these things actually work and they make a difference in the process.
One more question?
I just want to touch on a couple of things that was mentioned. The APEX program, so the state legislature allocated $4.2 million this year, an additional to start expanding the scope of the APEX program, as well as we partnered with Georgia Crisis and Access Line, who we contract for our crisis services line for the development of an app. So we got $1.5 million in the budget this year for the development of an app, just because new generation, people are more likely to reach out through a texting application, as well as it can serve as a tip line. So there's a lot of new exciting stuff that's going on in the department, and the state legislature was very kind together with the Commission on Children's Mental Health.
And what he's talking about, APEX, that's the school-based program that Dr. Lane was talking about earlier. And the neat thing about that with the funding from the legislature is that our department serves those people who are indigent and those with Medicaid. That is our primary population of those that we serve, because people who have other access to, Blue Cross Blue Shield and United and all that can get, hopefully, those services. The neat thing about this APEX program, the school-based program, is it doesn't matter what what insurance carrier you have. If you're a student in a school system and the counselor thinks that you might need some assistance, a teacher might see, even if a student wants to self-refer, which we've had more of those than I thought we would, they can go in as long as they have the parent's consent. And the parent doesn't have to drive them somewhere, especially when we have single parents that might be caring for other children who said, I really want my child, 16, 14-year-old to get help, but I'm dealing with a smaller child at home and I can't really get them the transportation that they need. The neat thing about this APEX program is it's right there at school, and as long as the parents agree to it.
I'm sure Dr. Lane can tell us that satisfaction is pretty high with this program. You don't see a lot of complaints about the tele nature of it.
No, and interestingly, I've had on more than one occasion, I've had experiences where, the first time I sat down and talked to the parent, and usually teenagers, where, after sort of towards the end of the appointment, the parent would basically just volunteer that they were shocked at how much their teenager had just talked to me, and that even if it was a teenager who'd been in therapy or been in treatment before, that I'd never heard my kid be as open and honest as they were with you today. And a lot of times I think it's because I'm on the screen, and that's what they're used to. They're less intimidated.
Well, I'm sorry.
No, I was just saying, it's a whole new generation, and obviously they're more comfortable many times texting or just video chatting with someone than they are sitting down and having a conversation. I don't know that that's always a good thing necessarily, but at the same time, if it works, great. I'll take what I can get, because it can be hard to get information out of a teenager. So if it helps them that I'm on the screen, great. That's certainly was not our intention. Our intention is just that there are so few, and it's I think only around 8,000 practicing child and adolescent psychiatrists in the country. Wow. There are so few of us, yet there is such a need that. Not, in my opinion, not utilizing telemedicine is just really a huge disservice. That's not even a strong enough word, but it is a sin. Thank you. I mean, it's a shame not to take advantage of those of us who are trained to do what I do, because and love to do what I do, and want to do it, but because of where I live and and that sort of thing, to have limits placed on that, both at a state level and at a federal level, and interfering with appropriate medical treatment because of appointments being via telemedicine. And unfortunately, that is where our state regulations and federal regulations are, although I'm cautiously optimistic that those are going to be changing in the near future. And again, we'll hopefully break down some of those barriers that currently exist to kids in particular receiving not just adequate, but excellent mental health treatment.
Potentially, there was a bill yesterday, a new bill at the federal level, and potentially we could see some change, which is good. So this is a part of the day where we have a pretty quick turnaround. We're just going to do our next.
Can I raise one more thing before
sure,
you throw us out
absolutely.
there? Because we need your help on one thing. So this week, Secretary Azar, who's the new Secretary of the U.S. Department of Health and Human Services, issued an announcement that he wants to change the regulations for Medicaid on non-emergency medical transportation. So currently, non-emergency medical transportation is a mandatory state Medicaid benefit. He wants to make that optional. In my opinion, that would be disastrous for all of you who operate in rural areas where that is a critical feature of your service delivery. So we need letters to the Secretary opposing this change. So we signed on to a letter just a couple days ago, so I'll send you a copy of the letter we signed. You all need to sign on to this and help us defeat this before it goes into effect, because it will be disastrous for your very business, basically.
All right. Well, we'll go get them. And 2:30, so obviously if you need to step out for a quick break, but we'll be starting this next panel. It's a great panel on rural health and rural economic development in 5 minutes or so. So take a short break. Thanks.
I want to come to